How's it going, guys? We have a difficult question for cardio, 2CK3 for studying for step 1. You have to ace 2CK eventually. 54-year-old male, progressively worsening shortness of breath. It started with doing errands about 6 months ago, and it's worsened to the point where he goes up a couple flight of stairs in his house, gets shortness of breath. He has no chest pain. He's got no symptoms of rest. He's on no medications, and he has an 18-pack-year history of smoking. He's been smoking since he was 18 years old. And his HbA1c is normal, 5.6. Should be under 6%. So 6 to 6.4 is pre-diabetic, 6.5% or greater HbA1c is diabetes mellitus. Any one random glucose 200 or greater is diabetes mellitus. 2 fasting glucose is 126 milligrams per deciliter or greater, diabetes mellitus. So baseline ECG shows no abnormalities. His resting echo shows an ejection fraction 55, should be 55 to 70, so lower end of normal. And then which the following is the next best step of management. Choice A, ambulatory ECG monitor, aka Holter monitor, aka 24-hour ambulatory ECG monitor is wrong. This is going to be the answer for 2 types of vignettes in USMLE. The first is if you have a patient with unexplained syncopal episodes, which often can be due to atrial fibrillation, where you get episodic/paroxysmal reduced perfusion to the brain. So you want to do an ambulatory ECG monitor to determine whether the syncopal episodes coincide with paroxysmal atrial fibrillation. So paroxysmal syncope, that's the first indication on USMLE. The second is going to be a patient who's had a stroke, a TIA, or retinal artery occlusion, where they go out of their way to tell you that blood pressure is not elevated, and the patient is usually over the age of 70 or has a notable risk factor such as hyperthyroidism for atrial fibrillation. Okay, so the point is choice A is when you're trying to pick up atrial fibrillation USMLE. Now, if you don't know how stroke, TIA, retinal artery occlusion relates to AFib, it's because you get turbulence, stasis within the left atrium causes a left atrial mural thrombus that launches off to the brain/eye. Wrong fucking answer. Choice B, carotid duplex ultrasound's wrong. So this is going to be when you have a stroke, TIA, retinal artery occlusion, where they go out of their way to tell you that the patient has high blood pressure. Okay? And if they don't mention blood pressure at all and the patient is 50s or 60s, it's still the answer. That makes it more difficult. Now, what the reason is because the greatest risk factor for carotid stenosis caused by atherosclerosis is hypertension. So diabetes mellitus, then smoking, then hypertension, those are the most acceleratory in order, diabetes being the worst, then smoking, then hypertension. In terms of causing atherosclerosis throughout the body, the coronaries, popliteals, abdominal aorta. But when we talk about the carotids specifically, hypertension eclipses diabetes and smoking. It's because the strong systolic impulse pounds the carotids, causing endothelial damage, causing atheromatous development there. So you get a plaque that launches off to the brain/eye. So if they tell you there's a stroke, TIA, retinal artery occlusion, we do the carotid duplex ultrasound is the next best step, and there's greater than 70% occlusion, that's called 70% symptomatic, stroke, TIA, retinal artery occlusion, or 80% asymptomatic, meaning the patient hasn't had one of those 3. But they can tell you there's carotid bruit, for instance. That's a sign, not a symptom. The point is, greater than 70% occlusion symptomatic, 80% occlusion asymptomatic. Answer is end arterectomy as next best step. I haven't seen carotid angiography as a step that NBME asks. Okay? If you're below those thresholds, you're simply going to do the triad of medical management. Number 1, antiplatelet therapy. There's different regimens, but it's to my observation, aspirin is sufficient on USMLE. Number 2, an ACE inhibitor or an angiotensin II receptor blocker. USMLE likes lisinopril. And number 3 is statin. Wrong fucking answer. Choice C, exercise ECG stress test is wrong. This is challenging, okay? The correct answer is D, exercise echo stress test. Now, this is what's going to go down. If they give you angina pectoris, which this patient doesn't have, and there's no silent pain as well, we didn't give you diabetes, nothing like that, sometimes elderly women. He doesn't have angina pectoris. We're not trying to diagnose ischemic heart disease. If we told you he gets chest pain going up a flight of stairs, we would do an exercise ECG stress test sometimes, okay? It's a lengthy seminar. You could also do a pharmacologic stress test of a patient who can't exercise, such as diprotonal thallium, aka cardiac scintigraphy. But my point is, if a patient gets predictable angina pectoris, where we're looking for ischemic heart disease, we'd say, okay, we'll do an exercise ECG stress test where we look for ST depressions. That's our next best step. The patient has to have a normal baseline ECG in order to do an ECG stress test, which the patient does have. Okay, if you have an abnormal baseline ECG, such as they tell you there's a right bundle branch block, anything they mention in there, just that's not normal, then you can't do an exercise ECG stress test. Okay, so even though his ECG is normal here, we're not looking for ischemic heart disease. We're not looking for angina pectoris. So what are we looking for? So choice D, as I said, is the answer. Well, we're looking for symptomatic left heart failure with exertion. So at rest, he's fine. No symptoms. His ejection fraction lower end of normal. But when he exerts himself, we have increased myocardial oxygen demand, he more than likely gets left heart decompensation where his ejection fraction falls, and we'll be able to detect that with a transthoracic echo with exertion, hence exercise echo stress test. If we give you an abnormal baseline ECG, that makes it even easier to do, but we'd still want to do this type of test anyway. So the point is, you do the ECG stress test when you're looking for ischemic heart disease. There's stable angina. You're looking for ST depressions. This guy doesn't have ischemic heart disease. He probably does have atherosclerosis, but it's not symptomatic. It's not what we're looking for. We're looking for left heart failure with exertion, which gives you pulmonary findings, pulmonary edema. So increased pulmonary capillary wedge pressure when LAP is high, so transitation into the alveolar spaces. Choice C, measure serum troponins, is wrong. I don't think I've ever seen that as an answer. Maybe once it shows up. But you do that after an MI. Okay, so you measure immediately at presentation, after 3 to 6 hours, after 6 to 12 hours. Sensitivity is debatable. Tests have gotten better. But you just want to track troponins because they're one of the tests we do to look for recent MI. Wrong fucking answer.